Now I invite our next speaker, Dr. Sonali Pandit.
Good morning, everybody. Today I am going to talk about how to rule out stroke clinically and confidently in acute vertigos. We all see acute vertigo patients in our practice, day-to-day practice. It's very important for us to not to miss the stroke when somebody comes with acute vertigo. So when you see a patient who is having severe vertigo, dizziness lasting for hours together, and he's vomiting, he's having ataxia, head motion intolerance, what comes into your mind? So these are the common conditions that are usually common differential diagnosis for acute vertigo. Vestibular neuritis, labyrinthitis. It could be first episode of vestibular migraine attack. It could be prolonged Meniere syndrome attack. It could be brainstem or cerebral stroke that we are all scared about, and multiple sclerosis. There are a long list of conditions which can be a differential diagnosis, but these are the common conditions. And out of this, vestibular neuritis and brainstem or cerebral stroke, these are the two conditions which definitely should be differentiated. So starting from history, when you start talking to the patient, you get many clues which can be a predictor of stroke, such as age, if somebody is above 50, 55 years with associated vascular risk factors, such as diabetes, blood pressure, hypercholesteremia. Start thinking, it could be stroke. Then these patients sometimes tell you that they get recurrent episodes of vertigo or dizziness. They have had this kind of episodes in previous months or weeks. That could be small TIAs. Usually the stroke has got abrupt onset of symptoms as compared to vestibular neuritis. Sometimes they can complain about craniocervical pain or severe new onset headache. Think about vertebral artery dissection or posterior fossa hemorrhage in those kind of patients. Somebody coming with gastroenteritis-like pictures, severe vomiting, nausea with acute vertigo. Think about superior cerebral artery stroke. Auditory symptoms, acute vertigo associated with deafness, not always is labyrinthitis. It could also be ICA stroke, anterior inferior cerebral artery stroke. Then obvious symptoms of diplopia, dysarthria, dysphagia, and cranial nerve palsies and weak sensory motor weaknesses obviously will point more towards stroke diagnosis, but not most of the times you will see those associated classical symptoms of stroke. Initially, they'll just have acute vertigo, nausea, vomiting. So coming to the general neurological examination, it's when the person walks into your clinic, just observe their gait. How are they walking? Just looking, look at those 3 videos. In this first video, this gentleman is taking help of 2 people to walk. In second video, this person is unsteady but still can able to walk. And this lady here, she can walk with eyes closed. So this is ICA and PICA stroke together. This is first day of vestibular neuritis, and this is day 3 of vestibular neuritis. So severe ataxia, also severe truncal ataxia. These patients are unable to sit, walk, and stand unaided. This diagnosis goes more in favor of stroke. Vestibular neuritis patient, as Dr. Srinivas always tells, they can walk, they can run if you make them comfortable and confident, they can walk fine. They're just scared. So these kind of things definitely remember. Then in other general neurological examination, focal neurological and oculomotor signs such as facial palsy, sensory loss, limb ataxia, hemiparesis, gaze palsies, all these are diagnostic of stroke. Then coming to 222 test, again I think this is invented by Dr. Srinivas, if I'm not wrong. You call it as 222 test. So we basically check 2 sensations, fine touch and temperature, on 2 sides, right and left side of the body, and 2 regions, head and body. You can actually map the brainstem just doing this simple test. You can use a wisp of cotton and a cold tuning fork test. Then unequal pupillary size, it's also called as anisocoria. Don't forget to look into the pupils and just compare the size of left and right. If you see unequal pupillary size, that is also an indicator of stroke. Then coming to our popular hints examination, Now look at this lady. She's got a positive head impulse test on left. So this is vestibular neuritis. So usually in peripheral lesions or vestibular neuritis, you'll get positive head impulse. And this is normal head impulse test. So by and large in stroke patients, you'll find head impulse test is normal. But barring few exceptions, one of them is ICA stroke. You can get a positive head impulse test on in ICA stroke. So now second part of hints is nystagmus. Now look at the types of the nystagmus here. Sorry. So, I don't know, sorry. This video कैसे play करायचं? सगळेच play करून द्या. So, pure vertical nystagmus, upbeating, downbeating nystagmus, pure torsional nystagmus. So, this first two are pure downbeating nystagmus, pure upbeat nystagmus. This is spontaneous nystagmus, not positional nystagmus. This is a pure torsional nystagmus. And direction changing nystagmus more goes in favor of stroke. So, if you see these kind of nystagmus patterns, think about stroke. Then test of skew, not very commonly seen. So this is cover-uncover test. If you see vertical misalignment of the eyes goes in favor of stroke. Horizontal misalignment is commonly seen, but not the vertical one. So if you happen to see skew deviation, which is extremely rare to see, but that goes more in favor of stroke. Now hints plus examination. So they have now come up with two more features to hints, original hints, that's hearing loss and ataxia. If somebody is coming with normal head impulse test, with direction changing, pure vertical, pure torsional, non-fatiguing, vertical torsional nystagmus, with or without skew deviation, hearing loss, which is present in ICA stroke, absent in PICA stroke, with severe ataxia, grade 2 or 3 ataxia, goes more in favor of stroke. So do not only rely on hints examination to rule out stroke. So there are some fallacies, there are some shortcomings of hints test. First is head impulse test is not easy to interpret. Okay, you need to really be doing this test regularly to understand the positive and negatives. It's not that easy, especially in acute vertigo patients. So beware of that. Then patients who are anxious, mentally impaired and unable to fixate their eyes, sedated patients cannot do this maneuver adequately. And false negatives often results from inexperienced practitioners. We are very scared of, hurting their neck. And people who have neck issues cannot really move their head properly. So inexperienced practitioners cannot do this test properly. And abnormal head impulse test can be present in ICA stroke, as I said. It's not always that positive head impulse test means peripheral diagnosis. It could be ICA stroke. And skew deviation, though it is a part and parcel of hints examination, it is extremely rare to be seen. So take-home message is rely on detailed clinical history and targeted physical examination. Your examination should focus on 222 test, focal brainstem and cerebellar signs and hints test. And by and large, severe ataxic patients, direct changing nystagmus, pure vertical, pure torsional nystagmus and normal head impulse test, unequal pupillary size and associated neurological signs go strongly in favor of stroke. Do not be in a hurry to do MRI. So hints plus examination is supposed to be more sensitive in detecting stroke if the MRI than initial MRI, which is done within 48 hours of onset of symptoms. So remember, and just by doing clinical examination, you can decide whether to send these patients to neurologist or you can treat as an ENT or otoneurologist on your own. Thank you very much.
Thank you, Dr. Sonali. Very nice presentation.